Hello, my name is Victor Perez, and I was in my pediatric rotation, and I'll be doing a presentation on gynecomastia. So, patient presented on 11/25/2025 at 6 p.m. ID is a 13-year-old black male. Source is self and reliable. He was brought by his mom. Chief complaint: liquid coming out of the left nipple started 3 days ago. HPI. Mr. TP is a 13-year-old male who is complaining of a lump in his left breast that he noticed recently. Patient reports first noticing the lump in the breast with a single episode of nipple discharge that occurred 3 days ago with no recurrence since. Patient denies anything making it worse or better. Patient describes the lump as being soft, tender, and movable. He describes the nipple discharge as milky/yellow color. Lump is only seen on the left breast, no other lump elsewhere. Denies any pain, 0 out of 10. Lump has been persistent since 3 days ago. Nipple discharge only occurred once 3 days ago, and it has not happened again. Medical history: he does have attention deficit hyperactivity disorder, which was diagnosed at 6 years old. He also has iron deficiency, which was diagnosed at 13 years old. No surgical history. Medication: he takes ferrous sulfate 75 milligrams per milliliter PO twice daily for iron deficiency, and methylphenidate 18 milligrams PO once daily in the morning. No known allergies. Social: currently living with both parents and one sibling, currently in the 8th grade, doing well in school, plays basketball with his friends, denies use of tobacco, vaping, alcohol, or recreational drugs, and not currently sexually active. Review of system: general, denies fever, shows fatigue, night sweats, or unintentional weight loss. Skin, denies changes over the breast, redness, warmth, rash, or lesion. HEENT, denies headache, visual changes, nasal discharge, sore throat, or ear pain. CV, denies chest pain, palpitations, syncope, or dyspnea on exertion. Respiratory, denies cough, wheezing, or shortness of breath. GI, denies nausea, vomiting, abdominal pain, diarrhea, or constipation. GU, denies dysuria, hematuria, or general discharge. Denies joint pain, swelling, or muscle weakness. MSK. Neuro, denies headache, dizziness, numbness, tingling, or seizures. Endocrine, denies heat or cold intolerance. Polyuria, polydipsia, reports recent voice deepening and some hair growth in genitalia. Psychiatric, denies anxiety, depression, mood changes, suicidality. Breast, which was a focused review system. He reports a left breast lump. Reports a single episode of nipple discharge 3 days ago since resolved. Denies pain, redness, warmth, skin dimpling, persistent discharge, or trauma. Hematologic and lymphatic, denies easy bruising or bleeding. Denies swollen lymph nodes. Now, physical exam: temperature was 97.5 Fahrenheit, heart rate 78, respiration 12, BP 110/60, SpO2 99%, weight 45.81 kilograms. He was in the 31st percentile. Height is 64.4 inches in the 77.6 percentile, and BMI is 16.1 in the 6.78 percentile. General, well-pairing adolescent male in no acute distress, alert and cooperative. HEENT and neck, normocephalic, atraumatic, perla, EOMI intact, mucous membranes moist without lesion, neck supple, no thyroidomegaly, no cervical lymphadenopathy. CV, regular rate and rhythm, no murmurs, rubs, or gallops. Respiratory, clear to auscultation bilaterally, no wheezing, rales, or rhonchi. Abdomen, soft, non-tender, non-distended, normal bowel sounds. Breast, left breast palpable, small, mobile, non-tender, subareolar mass without overlying skin changes, no erythema, dimpling, puree de orange, or warmth noted. No nipple retraction, no active discharge expressed on exam. Right breast shows no mass, tenderness, or skin changes. Axillary exam shows no lymphadenopathy bilaterally. GU, normal external male genitalia, meaning normal and appropriate for age, 10 stage 3. Warm, dry, intact, no rashes or lesion. MSK, normal range of motion in all extremities, no joint swelling or deformities. Um, Alert and oriented, cranial nerves 2 to 12, grossly intact, strength 5 out of 5 in all extremities, psychiatric, appropriate for mood and affect, behavior development, appropriate. Workup: so at the office, all we did was a hormone panel for prolactin, testosterone, luteinizing hormone, follicular state stimulating hormone, thyroid stimulating hormone. all were within normal limits, and we ordered an ultrasound to be done, ultrasound of the left breast. So again, assessment: 13-year-old male presenting with a unilateral left breast mass and a single self-limited episode of nipple discharge occurring 3 days prior, now resolved. Physical exam is notable for a mobile, non-tender subareolar mass without overlying skin changes or lymphadenopathy. The most likely diagnosis is pubertal gynecomastia, given the patient's age, subareolar location, benign exam features, and absence of recurrent discharge. Pubertal hormonal fluctuations commonly cause transient unilateral or bilateral breast tissue enlargement in males. So the plan, we're still waiting on the breast ultrasound to be evaluated for a mass to see if it's solid versus cystic or ductal involvement. This is to rule out other malignancies and to make sure it's a true gynecomastia. We also provide a reassurance and education regarding pubertal gynecomastia as a common benign condition. No medication is indicated at the time. Avoid chest manipulation and frequent checking of mass. We did schedule a follow-up in 2 to 4 weeks to review imaging. If testing is normal and mass is stable, monitor every 6 months. Therefore, refer to endocrinology and breast specialists if ultrasound is suspicious as mass persists more, or if the mass persists more than 6 to 12 months. And then we also advise to return to the office if fever, redness over breast, new nipple discharge, rapid growth of mass, severe pain, or generalized illness is occurring. So now I'll be talking about gynecomastia. Here you can see the normal male breast tissue and how gynecomastia involves the glandular tissue. So epidemiology, gynecomastia has a trimodal age distribution, peaking in 3 life stages, known as newborn, adolescents, and elderly men. Neonatal period prevalence is estimated to 60 to 90% of newborn males. Causes are due to high levels of maternal estrogen passing through the placenta. Resolution almost always regresses spontaneously within 2 to 3 weeks after birth. In the adolescents, prevalence has shown a wide range from 4 to 69%. In this age group, causes can be due to temporary hormonal imbalances during puberty, where estrogen levels rise faster than testosterone levels. Resolution typically occurs within 1 to 3 years, with incidence decreasing in the late teenage years. And then again, elderly adults, prevalence increases again in men over 50, with estimates suggesting up to 70% of men between 50 to 69 years of age are affected. Causes are combined factors including natural decline in testosterone, increased conversion of testosterone and estrogen, and higher rates of other conditions like obesity and liver disease. Resolution does not always occur and can persist in old age. Etiology and risk factor. So first one is hormonal and age-related factors. So natural hormonal changes commonly occurring in puberty, old age, and birth due to fluctuation of estrogen and testosterone. Can also be due to hypogonadism, which is a condition where the body does not produce enough testosterone. And it could also be due to age. Again, aging leads to hormonal imbalances that increases the risk of gynecomastia. Other factors are medication and substance use. Medications such as anti-androgen, anabolic steroids, and some antidepressant heart medications and antibiotics. Substance use such as chronic use of alcohol, marijuana, heroin, and amphetamines can alter hormonal levels. Herbal products such as tea tree and lavender have been linked to gynecomastia due to the estrogen-like compound. Other medical conditions such as liver and kidney disease, liver failure, cirrhosis, and kidney failure can disrupt hormonal imbalances. Tumors such as testes, adrenal glands, or pituitary gland tumors can produce hormones that cause gynecomastia. And then also thyroid disorders, overactive, and in some cases underactive thyroid can be the cause of this. Other risk factors include obesity. Excess body fat can increase the conversion of testosterone to estrogen, leading to both true gynecomastia and fat deposition that mimics it, pseudogynecomastia. And then malnutrition and starvation. Prolonged malnutrition can drop testosterone levels while estrogen levels remain, creating imbalances. Pathophysiology. So gynecomastia is due to the imbalance between androgen and estrogen levels, leading to proliferation of the breast glandular tissue. The imbalance can be caused by a relative or absolute deficiency in androgen and excess of estrogen, or both. This hormonal disruption can be due to physiological changes like aging or puberty, underlying medical conditions, or side effects of certain medications. So again, hormonal imbalances, major cause of this. Estrogen stimulates the growth and proliferation of breast tissue. It increases in aromatase activity, which converts androgen into estrogen, especially with those with higher fat content. Certain tumors produce excess estrogen or hormones like testicular and adrenal tumors. In the hormonal imbalances, also androgen have an inhibitory effect on breast tissue growth, but this can be due to a decrease in testosterone production can occur due to conditions affecting the testes, hypothalamus, or pituitary gland. Also been shown that sex hormone binding globulin, um, sex hormone thyroid, excuse me, sex hormone binding globulin. High levels of this can bind to testosterone, reducing the amount of active testosterone available to the tissue. So this can be another reason why gynecomastia occurs. And then the imbalances results in estrogen effects being dominant, causing growth due to increase in levels of estrogen and decreased levels of androgen. Some other causes are medication, obviously, like heart medication like spironolactone, digoxin, alpha blockers, and ACE inhibitors, anti-ulcer drugs like cimetidine, prostate/hair loss medication like finasteride and other 5-alpha reductase inhibitors, antipsychotics like first-gen antipsychotics like phenothiazine, antifungals like ketoconazole, and others like diazepam, phenytoin, human chorionic gonadotropin, and certain antibiotics can also cause gynecomastia. And again, just like the last slide, physiological changes such as adolescence and increased age also cause gynecomastia. So what is gynecomastia? What are the clinical manifestations? It's usually enlargement of the breast, which increases in breast size due to the growth of the breast gland. It can be firm or rubbery lumps, tenderness or pain to touch, severity varies. There can be nipple sensitivity or discharge, swelling or puffiness of the breast and nipple area, and asymmetric, meaning one breast may be larger than the other. Um, Typical workup. So what we do is we usually take a history and physical exam, which allows us to rule out other causes. We can also do laboratory hormonal panel, which identify crucial hormonal imbalances, which include, again, testosterone, estradiol, luteinizing hormone, follicular stimulating hormone, human chorionic gonadotropin, and prolactin. Other labs such as liver function tests, renal function tests, thyroid stimulating hormone to rule out underlying medical conditions. And then we can also do breast imaging to help differentiate from true gynecomastia and a malignant mass. Typically, we do a breast ultrasound first, and then we switch to mammo if it's suspicious. And for men, we can also do a scrotal ultrasound. If we do a GU exam, we want to check the testicles because, again, testicular mass can cause change or an imbalance in hormones. So management, there's different types of management that you can do. So medical treatment and lifestyle changes. What we can do is discontinue the medication that are causing the manifestation. Weight loss through diet and exercise can reduce the appearance of gynecomastia. Specific chest exercises incorporating both cardiovascular and resistance training into your routine can help focus on major muscle groups. Though exercise does not treat clinically gynecomastia, it can help tone the muscle beneath and reduce overall body fat. We can also improve our diet by including more antioxidants and focusing on protein, vitamin D, and zinc to help the testosterone production. We can also limit alcohol consumption because it has been linked to be causing gynecomastia. Medication management is also used to address the hormonal imbalance, specifically like SERMs, aromatase inhibitors, androgens, and clomiphene. There is also surgical options like liposuction, surgical excision, or the combination of both. And then compression garments are also used after the fact or can be used temporarily, but garments don't usually provide a permanent solution. I'll be talking more about this on the following slide. Selective estrogen receptor modulators. So this is the serums I was talking about earlier. Serums like tamoxifen are used to treat gynecomastia. They work by blocking the effects of estrogen in the breast tissue and are often used as an initial treatment option for surgery. Serums work by blocking the effects of estrogen on the breast tissue, helping to reduce the enlargement. While they cannot completely eliminate the condition, it has been shown to partially reduce in size. Serums also help in alleviating pain, and typically, tamoxifen taken PO 10 to 20 milligrams per day for about 3 to 6 months. Again, we try not to go to surgery right away, but if all else fails, like the serums don't work and lifestyle modifications don't work, um, then we go to the combined liposuction and excision of gynecomastia. Here, obviously, anesthesia is performed under general anesthesia. Small incisions are created, 1 to 2 per side, in discrete areas such as the side of the chest or under the areolae to allow for liposuction and excision. Incisions are typically done along the edge of the areola to remove the glandular tissue. Liposuction, they use a solution such as tumescent fluid or wetting solution, which is injected, and then a cannula is used to suction out the excess fat tissue from the chest area. And during the excision, the firm glandular tissue that causes the prominent breast-like appearance is surgically cut off and removed through the periareolar incision. Again, that's typically on the side along the edge of the areola. And then drains and dressings are applied. Drains are only used temporarily, and pressure bandages or compression garments can be used to reduce the swelling and help the skin conform to the new contour. So here you can see the puffiness, and then it's fixed. So there are complications, or complications can occur. When it comes to gynecomastia, physical complications occur such as tenderness and pain, skin irritation, chafing, posture problems due to wanting to hide the appearance of their chest, and then exercise limitations, which can cause discomfort, self-consciousness, which can limit participation, and then again, asymmetry can cause aesthetic distress. There are also surgical complications after getting gynecomastia surgery. So hematoma can occur after the procedure, which is a collection of blood under the skin, which can lead to a second surgery. Seroma, which is a bit of body fluid, can occur, but it can also be drained. Infection is rare, but still a possibility. Numbness in the chest area can occur from nerve disruption during the procedure. Scarring is a potential risk, and then there's always anesthesia complications such as shortness of breath or chest pain, which would need immediate medical intervention. And that is gynecomastia, and these are my references. Thank you.